So with that, I'm going to hand it over to Andrey. So Andrey is the Chief Medical Officer and SVP of Behavioral Health at Solera Health. He is a practicing pediatrician and was the Chief Medical Officer for Center for Medicaid and CHIP Services, prior to which he co-founded the software company Care at Hand. He's also been an advisor to Adaptation Health, so pleased to hand it over to him.
Thank you so much. Thank you, everyone, for having me here. Can I borrow? Yeah, thank you so much. For those of you that may have seen me over the past 3 months, I am no longer wearing a boot. I tore my Achilles in December and got to enjoy our medical system, and it worked out well. I'm ambulatory now, so that's why I have a little bit of a limp. Luckily, I had access to care, and care was reimbursed, and I had insurance. So there's so much here to unpack. I wanted to ground us in some research and shared foundation, most of which I'm sure you all are already pitching or have explored and fully understand. But I thought it might be good to get a common lexicon here in place. Just for a little bit more context where I'm coming from, I had the fortune of working at the federal level to help lead the national Medicaid program. And I learned just how highly variable each state's Medicaid program is. And at the same time, I also learned the local nuances of which social determinants of health are driving what outcomes in what geography. And Arizona is a pretty unique place, so I'm going to reference some commonly applicable literature, and I'm going to bring it back to the data applicable to Arizona. The other thing to note is I came to the US when I was 5 from Ukraine. My family benefited from the Medicaid program for 3 years. I fortunately was never particularly sick as a kid, but the program and then other types of programs like Medicaid, for example, HUD housing, are what allowed me and my family to get through a very challenging financial time. And so I am personally indebted to the program, so there's a little bit of bias there. I'll start off with why are social determinants of health important. By raise of hands, has anyone else seen this slide before? Okay, I'm surprised. It's only like 15%, 20% of people. Ingrain this data into your brains. If it's probably already tacitly in there, but it's good to have the hard numbers. So Schroeder, 2007, put this in New England Journal of Medicine, based it off of OECD data. And it basically looked, researchers looked at the leading causes of premature mortality. And the thing I want to point out here is only 40% of premature death is attributable to stuff that people like me, doctors, can influence, sort of. So 10% of premature mortality is because of actual healthcare. 10%, that's it. So I've been fortunate to train some of the best institutions in the country. If you bring your kid to me, really only 10% of the patient population that I can influence as a nighttime hospitalist pediatrician in the DC area, only 10% of the population's premature mortality will be because I can go and provide evidence-based care. There's genetic predisposition, 30%. And okay, you're born with genetics, but there's actually epigenetic influences because of traumatic experiences, average childhood events. So actually, that's not all purely genetic. There's upstream determinants influencing that. The rest, social circumstances, environmental exposure, behavior. The premature mortality attributable to those root causes is enormously influenced by upstream health determinants. To reframe this, Braverman was funded by Robert Wood Johnson Foundation to essentially establish a framework for social determinants of health. Who's seen this framework before? Okay, so same 20% of the people. I love it. Okay, you guys are well researched. I particularly like this framework because it allows for policy design to be actionable, technology design to be actionable, and in general, solution design to be actionable. And so health, overall health, influenced by medical care. So remember, only 10% of outcomes is medical care. Personal behavior. Okay, we have choice. We can make a choice. We can choose to go work out in the morning if when we walk outside we don't get shot because of a high violence rate or there's maybe a gym or not a gym available, but okay, personal behavior. But then living and working conditions, hugely influential in our health outcomes. And then economic and social opportunities. And I'll get into that, the latter two here in just a second. One thing that this framework does not address, that in my own personal journey over the past 5 years into the behavioral health space has identified for me, is stigma is not given enough emphasis in terms of stigma as a driver of health outcomes. And I think stigma pervades economic and social opportunities, living and working conditions, especially in the case of substance use disorder, opioid use disorder, the space that I intimately work in now. So stigma is something we can perhaps get into later in the day here. Now, how do these social determinants translate into this area? And in particular, I wanted to challenge our thinking about social determinants of health, because when we think about population health is the distribution of outcomes over a group of people. And so we often think of people, low SCS as an important driver of outcomes, race as an important driver of outcomes, educational level is an important driver of outcomes. And as a white male, okay, white and male, advantage, right? So oftentimes, white and middle and or upper class, those variables are usually on the better end of outcomes. There's some fantastic research done by folks out of Brookings that basically looked at the white middle-aged population, and it wasn't higher SES, it was lower SES. So white and middle-aged, which typically is not thought of as, oh, they're subject to health disparities. In fact, if we look at mortality rates over the last several decades for some of the higher GDP OECD countries and compare that to white, middle-aged Americans, the mortality rate that we've experienced has been almost exponential. So the impact of social, and so why is that, right? So this 80-page paper basically dives into progressively worsening economic opportunity, work opportunity for people that are lower level of education. So if middle-aged whites can be hit massively by upstream health determinants, particularly economic opportunity for folks with lower educational status, everyone can be hit. And to dig in a little bit deeper, so Arizona is particularly challenged by this problem. And when we look at deaths of despair, so this was defined as deaths of overdose, deaths by suicide, and liver cirrhosis due to alcohol, Arizona is like squarely in the dark red, dark orange here. So the problem is particularly pertinent here. And so kind of what do we do about it? I don't think any one startup is going to solve this problem, but if we look at the role of what happens when you increase the median household income by $1,000 per year, that alone is associated with saving 10 people's lives per year. Now, that takes a lot of change, that's macroeconomic influences, but the role of income, particularly for people with lower SES, is profoundly influential. So as we're pitching, and remember, I used to run a software company, a very small software company. I now work for a larger software company. When I was pitching oftentimes to either MCOs or states, we have to keep in mind, like, how is our solution going to influence these massive determinants of health? And it may not directly, but it's important to tie in if it can in any way. And so I'm working in the behavioral health space now, and I thought it'd be relevant to share some literature around overdose deaths in particular. Opioid crisis is everywhere. It's in the news, top of mind appropriately. It's one of the largest, most prevalent causes of death that we've experienced in the last several decades. But this literature, this study was published in Science recently, basically highlights opioids are just one of the multiple waves of overdose deaths that we're experiencing, and it's probably not the last one. And that's a little bit terrifying. And what this data shows is, on the left figure is overdose deaths attributable to the various types of drugs. So, here we have our heroin line with the red. We have our prescription opioids, synthetic opioids, which is the really scary one, fentanyl, carfentanil. But methamphetamines are back on the rise. Cocaine before in like 2005, 2006 was a really big influence. Cocaine is back on the rise. So when we control the opioid epidemic, well, then what's next? And we have to keep in mind as we're developing our solutions, are we just developing one-point solution for this one problem today? Or are we helping state leaders, managed care entities, policymakers, most importantly the consumers, are we helping to get at the root causes? And what this figure on the right is highlighting is it's almost a perfectly exponential curve in increases in mortality because of one of the biggest causes of deaths of despair. So how do we get at the root causes of that? And the social determinants squarely factor into the contribution to this exponential growth in overdoses due to drugs. And again, to bring it back home here to Arizona, we've got a problem. We've had a problem brewing over the last several decades. In Arizona, it's less so heroin, more prescription opiates, but it'll be probably something else. And so what can we do? What can we as entrepreneurs do? What can we as innovative policymakers do to anticipate the next wave and hopefully prevent it from happening? Okay, social determinants. Now, engagement. So, okay, let's say we figured out a really interesting thesis on how to impact social determinants of health. Well, how do we actually engage our consumers in the effect size or the benefit of whatever solution we're proposing? So I thought it was only appropriate that Center for Healthcare Strategies did a study on this topic, and it was work that was in collaboration with Commonwealth Fund. And essentially what they looked at a few years ago was 200 consumers that were surveyed. They were dually eligible, so not just Medicaid, but Medicare eligible as well. And they inquired about their access to technology and how their behaviors are influenced by technology. And I thought these were some interesting findings. By raise of hands, has anyone looked at this data before or seen this data? Okay, hopefully the Center for Healthcare Strategies folks. You like that? It's well done. I thought it was actually well done literature, not just because you guys are here. So, punchlines. What the research found was telephones are the most common technology used to communicate with providers. Super high-tech phones, right? And okay, so this is a couple years old data, but it's not 1980s data. It's not 1990s data. Phones are still the predominant way of communicating information. So 67 of these folks had access to a landline. I was surprised by that. I thought it was actually a relatively low number. 62% with a mobile phone, 37% had a smartphone that could connect to the internet. That number is going to keep rising, but it's not 90%. And 39% had the ability to text, but few used this function. This is, I think, the operative one, right? So there's some access to high-tech things like text, but are they using it? Are they actually engaged in it? Do they have a reason to use the text? And I thought this quote was interesting. The survey confirms that technology-based initiatives should augment, not replace, the one-on-one telephone or case manager-driven communication with members. The human touch plays a massive role in engagement here. Next finding, many members have access to computers and the internet, but prefer to use the phone to communicate, so reinforcing the prior finding. So 41% had access to a computer or a tablet. And by the way, this was not either their computer or tablet or like a neighbor or a friend's. So this isn't necessarily a computer or tablets in the home. And again, the software company I used to run was all focused on mobile technology. I think these may be slight underestimates of actual penetration of mobile technology in this space. But importantly, we cannot assume reflexively that text-based or app-based technologies are going to solve our engagement problems. So not to burst people's bubbles, but it's a reality. 50% had internet access either in their homes or another location. Less than 50% use computers or tablets to receive health information from providers. Interestingly, security, fraud, and privacy were pretty significant concerns in the behavioral health space that I don't have an exact study to cite for you, but just from my experience, it is exponentially high or significantly higher in terms of the security risks and privacy risks. And 50% of folks talked with their health plan customer service department over the phone during the past months, as opposed to through some kind of electronic communication. And the other finding here is most members prefer the in-person interaction, so we're reinforcing a theme here. In-person, that high-touch experience is the most prevalent form and perhaps the preferred form. There may be different prevalent and preferred, but the most prevalent form of learning about health information and interacting with the health plan. Another study, so McKinsey did in 2014, right as the Affordable Care Act was actually turning on, as the exchanges were turning on, as Medicaid expansion was kicking in, they surveyed 1,100 consumers, and it was a mix of people that are already Medicaid eligible, people that are eligible but not enrolled in Medicaid, people that are now going to be newly eligible, and then they had a control group, which was a commercially insured population. Now, this wasn't published in peer-reviewed journal. I don't know the exact methodology here. I don't know if this is statistically significant for all the methodologists out there. These findings may just be smoke signals and not actual statistically significant findings, but it's interesting trends. And so here's what they observed. When we look at the way in which, the medium through which an individual learns about health information, and the options were websites, TV, magazines, and search engines. If we look at Medicaid eligible folks, it's somewhat of an even distribution. If we look at the newly eligible folks, which is typically people that are low income and tend to be younger, as well as the commercially insured population, the use of websites was significant is the wrong word, was higher than a typical non-dual enrollee and also higher than dually eligible folks. So again, if we're going to try to communicate information to our members, our website's the most effective way, perhaps not. TV spots, magazines, I mean, print media, I'm not an expert there, but may not be the best forum, even though it suggests that it may be equally as impactful as websites. And then search engines, I think this is probably going to be continuously increasing, including with the increasingly tech-savvy duals population. But importantly, these are not technophiles typically. Many of the folks we're trying to reach out to. The other important data point here is when trying to make an important healthcare decision, what individuals influencing your decision the most? And amongst non-dual enrollees, their healthcare provider, which I thought was interesting, and amongst duals, it's split between the healthcare provider and a government agency. In my own ethnographic research of the Medicaid population, the most common influence on deciding what someone's going to do was typically their friend or peer or family member. So I don't think this data necessarily accounts for that very effectively, because obviously, like, someone who's an adult isn't necessarily going to refer to their parents for guidance, so limitations in the study. But importantly, look at the commercially insured population. Their employer has a massive influence on how they're learning about and making healthcare decisions. And then finally, so what do we do about it? And I thought McKinsey did a really nice job summarizing some of their data here. So multi-channel, omni-channel approaches make sense, and I'm excited to hear what solutions here can do about that. Network and benefit design. So getting a high value network of providers is something that's something I'm very personally passionate about. I can tell you in a second what we're doing about that. Payer-provider collaboration, so making sure there's alignment and financial incentives amongst providers to do the right thing and also get paid well for it. Care management, so having a population-specific and sub-segment-specific approach to care coordination, care management, and then technology. We're all here because of the technology opportunities. And so to conclude, I'm very fortunate to be able to kind of pick where I spend my time. And Solera is a company that I invested my time and money in a year ago. I was on their advisory board over the past year and recently joined as an operator there. And the entire thesis, which I think speaks to some of these challenges, is that there are so many providers out there, and especially in the case of substance use disorder treatment, particularly opioid use disorder treatment providers. So many providers, 15,000 to be exact, and less than a third of them are actually providing evidence-based treatment. And for a health plan who's trying to decrease emergency room use, unnecessary lab testing, unnecessary residential treatment, crappy care, how do they pick which one's a good provider? And so Solera has already figured out this really elegant model in the diabetes prevention space with providers there, aggregating a fragmented ecosystem, vetting for the good ones, and paying them based on outcomes. I basically stepped in and am doing that for the behavioral health space. And these slides will be available. Folks can learn more about them. But I think the important thing to keep in mind is we have a patient population, a consumer population that they're not necessarily worried about, like, am I going to go make it on time to my doctor's appointment? They may be more worried about where's my next meal coming from. Or they may be more worried about, I don't want to be dope sick. Or they may be more worried about, how do I get up and get to the mailbox and actually have enough function to get there? And an app isn't necessarily the first top of mind thing they're thinking about. So how do we engage them and create true value, not what we think is value in our minds as entrepreneurs, but what is truly meeting a must-have need for them? And so with that, I'm very excited to learn more about what you guys have to say. Thank you.